Welcome to the American Academy of Sleep Medicine's webinar, Introducing Telemedicine into Your Sleep Practice. I'm Lawrence Epstein, and today I'm going to be joined by Lisa Mazur, a partner at the law firm McDermott, Will & Emery, who specializes in digital health regulatory and compliance issues. In this time of pandemics, quarantines, and social distancing, providers and patients are looking for ways to provide and receive quality health care in a way that is safe and effective. Telemedicine is one method for accomplishing this. Sleep medicine is particularly well suited to use telemedicine. This webinar is designed to provide you with information that will help you decide whether and how best to use this tool. The information provided in this webinar is correct as of this date, March 19th, 2020. However, this is a rapidly changing landscape. You will need to continually update yourself on changes, particularly in the regulatory arena. Today, we will start by describing what telemedicine is and how providers can use telemedicine to provide sleep medicine services. We'll describe resources that are available for you to use to set up a telemedicine service of your own. And then we'll spend a lot of time talking about legal and regulatory issues, particularly the changing telemedicine landscape. What is telemedicine? It's the use of medical information exchanged from one site to another by electronic communications to improve a patient's clinical health status. People often use the term telehealth interchangeably with telemedicine. However, we're going to use them differently. Telehealth is a broad term for electronic exchange of medical information. It doesn't have to involve clinical services. It can include things such as exercise, diet, and wellness. Telemedicine is specifically a patient-clinician encounter using electronic communication. So the first question, who pays for telemedicine? The information on this slide is the status before the coronavirus epidemic. All the payers to some degree pay for telemedicine, but there are differences. Medicare pays, but with restrictions. Up to now, they have required audio-video conferencing, specifying the type of equipment and location of the patient. They needed to be in a physician shortage area and go to centers that can provide them a communication with the physician. Medicaid pays for telemedicine in almost every state. However, the rules governing the use of telemedicine are determined by the state and so vary greatly from state to state. You will need to check to see what the coverage policy is in your state. Private insurance plans have been behind the government in terms of paying for telemedicine, but they're beginning to catch up. 36 states and the District of Columbia have parity laws that require that private insurers cover telehealth the same as they cover in-person services. However, each company can determine its own plan, and the coverage is very plan dependent. You need to check with each of them. This information comes from the American Telemedicine Association and shows what the state of parity laws are in each state. You can check on this map or at their site to see what it is in your state. It shows both coverage parity, meaning that they will cover the same illnesses by both methods, and reimbursement parity, that they'll pay the same amount. They also provide information on parity laws for Medicaid policies. Again, check for your state either here or through the American Telemedicine Association. There are several types of teleservices. There's teleconferencing, which is communication between multiple remote sites, similar to what we're doing today. Teleconsultation, which is interaction between clinicians, either via computer or telephone. Telemonitoring, which is the remote collection and transmission of data, something that's very familiar to sleep physicians. And then telemedicine, that patient-clinician interaction. Two types of telemedicine categories, synchronous and asynchronous interactions. Synchronous interactions are essentially live interactive visits. They function as a live visit, and you should apply the same clinical standards to providing care. They're just separated by distance, even though they're going on in real time. Asynchronous interactions, on the other hand, are separated by time and space. They include remote interpretation of data, store and forward technology where information is collected and reviewed later, e-messaging, and self-directed care, such as online CBTI programs. So what are the benefits of telemedicine? They provide increased access for remote patients who can't get to a sleep physician. Reduced wait times. They have proven to be cost-effective. Improved quality of care. And this doesn't mean that the care that you get is better. It means that more people will have access to specialized care, to board-certified sleep medicine physician, raising the overall level of quality of care. High patient satisfaction. As people become more and more dependent and familiar with electronic communication devices, they are preferring this as a way to talk to their doctors. And most important for the current situation, reduced exposure time. Less face-to-face if you can do it via telemedicine. So telemedicine is already quite common in sleep medicine. In-lab sleep studies are a form of remote monitoring. Home-based sleep studies are store and forward technology where the patient collects the data overnight and brings it back to the sleep center. Compliance monitoring of PAP machines are something sleep physicians do every day. And teleconsultation, speaking or communicating with primary care or other specialty doctors about their sleep patients. This is an example that most sleep physicians are familiar with, getting data from the PAP machines so you can review them with your patients or make changes. There are a number of reasons to expand participation in telemedicine by sleep physicians. Increasing access. Sleep medicine tends to be a high patient to specialist ratio, meaning there are a lot of patients with sleep disorders and not that many sleep physicians. In addition, there tends to be a geographic maldistribution. As specialists, sleep physicians tend to congregate in urban academic areas, limiting the access that people in remote areas have. And again, for our current time, telemedicine is very valuable in a time of limited mobility or to reduce exposure. As we mentioned before, we can improve overall quality of care by getting more patients to physicians who are trained in sleep medicine. We know that the majority of sleep patients are not diagnosed, increasing overall healthcare costs. So by getting more patients properly diagnosed, we can both improve their health and reduce healthcare costs. And as I'll show you, sleep medicine is particularly well suited to telemedicine and is being shown to be effective in sleep patients. So in thinking about this talk, I went through the things that a sleep physician does to see which ones are appropriate for telemedicine. I listed all the things that we do under diagnostics and therapeutics and under patient management. And as you take a look at this list, you'll really see that they're all amenable to use of telemedicine. There really is very little that we do that cannot be done via telemedicine. I stated that telemedicine can be effective in patients with sleep disorders. Here is some of the data. This is data from a prospective trial looking at 90 patients evaluated for obstructive sleep apnea. They had their initial and follow-up visits with the physician either in person or by video conferencing. And then they looked at outcomes, specifically patient satisfaction and adherence to PAP therapy. And what they found was there was no statistically significant difference in any of the measures. Patients were just as happy, and their PAP adherence was just the same, whether they did it via telemedicine or in person. This is a recent trial looking at PAP management. This is a randomized controlled trial of 483 patients diagnosed with obstructive sleep apnea who were on PAP therapy. They were then randomized to receive their follow-up and management either monthly via telemedicine, in which their data was monitored and they would be contacted only if there appeared to be a problem, monthly in person coming to the clinic, or coming to the clinic every 3 months. It was a 6-month trial, and what you see is that that management via telemedicine was non-inferior to in-person, or at least frequent in-person. This is the telemedicine group, and you can see a higher percentage of those patients actually got improved adherence over time compared to the in-person visits. The number of people who did worse which is the black group here, actually went up more in the group that had a longer duration, probably due to reduced time in monitoring. This is the actual data from the machines, and you can see improvement in adherence time on PAP in the 1-month group, both by telemedicine and in person, and a reduction in the 3-month group. Similarly, for the actual minutes per night worn, increased in the telemedicine group and in the 1-month group, and reduced in the 3-month group, showing that telemedicine can be very effective in helping your patients adhere to PAP therapy. Probably the group that has been using telemedicine the longest has been the VA system. They have a very extensive Telesleep program, and they recently published an analysis of some of their outcomes. They found that they were able to reduce the time to getting effective care. They found that an e-consultation reduced the time from referral to getting started on PAP therapy from 60 days down to just 7 days. They also looked at what was the effect of doing in-laboratory versus home-based testing on eventual PAP adherence, and found no difference between the in-lab and the home-based testing groups. They have a specific PAP adherent management program and found that the outcomes were equal between the in-person and the telemedicine groups. No difference in adherence and higher patient satisfaction. From a cost effectiveness perspective, they also found reduced cost with telemedicine. The VA pays people if they have to travel long distances, and they found they were able to reduce their travel costs 145 miles and 142 minutes per visit through the use of telemedicine. Telemedicine is also effective in other disorders, not just obstructive sleep apnea. This is information from a small study that was done on patients who had insomnia and depression. They were treated with cognitive behavioral therapy using 10 50-minute weekly treatment sessions. The sessions were done using video conferencing, with the patient showing up at their primary care doctor's office and the therapist in their own office. And what they found was improvements in both sleep and mood scores. You can see here that the patient had about the same amount of time in bed, but their time asleep increased and their sleep efficiency increased. And you can see that for other sleep parameters, reduction in the sleep onset latency and the wakes after sleep onset, immediately after therapy and in long-term follow-up. They also saw improvements in their insomnia severity index as well as their depression scores. Because of the shortage of trained behavioral therapists to deliver cognitive behavioral therapy for insomnia, a number of online programs have been developed. This is data from one physician-recommended web-based self-directed program. Looking at 500 consecutive patients, they measured their sleep outcome improvements. It's set up for the patient to follow a series of modules, 6 cores they call them. And what you can see is the improvement over time in both wake after sleep onset and sleep onset latency, improving over the course of their interactions. Similarly, their sleep efficiency improves, and both of those measures met their targets for initiating therapy. So how would you go about starting a telemedicine program? It requires some planning, and these are some of the things that you should look at. First, identify your target audience. Are you just going to include your current roster of patients, or are you going to try to expand your geographic area? How do you want to deliver the service? Are you going to use a center-to-home model where the patient is using their computer or phone, or a center-to-center model where the patient goes to another center that has a computer setup? You need to develop a workflow plan that works for your practice. Are you going to set aside a day just to do telemedicine, or integrate it in between the patients who come to your clinic? You need to identify and obtain the hardware and software you need to set up the program. And then it's important to understand the telemedicine regulations and how to get paid. And we're going to spend a lot more time talking about that later in this talk. We don't really have time to go into all of these things in detail, so I want to point out a number of resources you have for starting a program. These are resources available through the American Academy of Sleep Medicine, and you can access them through the telemedicine page on the website. They include a sleep telemedicine implementation guide, which walks you through the steps of setting up a program, and a position paper on telemedicine, which sets the clinical standards for using telemedicine. In addition, the American Academy of Sleep Medicine has developed a telemedicine platform called AASM Sleep TM. During this time of need, the Academy is going to be offering this at a discounted price, and you can find more information about this on the website. The bottom line on the clinical guidelines is you need to continue to provide high quality care. The clinical standards you should use for telemedicine visits should be the same that you would use in a live office visit. You should perform the same key elements on the medical history as if the person was sitting in front of you. The clinical guidelines that you follow should be the same as you'd use for a live visit. And documentation standards should mirror those of an in-person visit. In terms of the regulatory issues, you need to understand the differences between the government-based and commercial payers and between the different commercial payers. You need to know what are the different licensing and credentialing requirements and how do you get paid. And we're going to spend the rest of the time talking about these issues. So to summarize my section, telemedicine is something that is well suited for sleep medicine practices. You can get equivalent clinical outcomes for sleep-related clinical services. The standards for telemedicine should mirror those of live interactions, and you really need to know what the regulations are. And towards that end, I'm going to turn you over to my co-speaker today, Lisa Mazur, who is going to go into these in a lot more depth. Lisa?
Now we'll continue the conversation to explore the different applicable legal issues that governs telehealth, telesleep practices. The various different laws and regulations that apply will really vary depending on the types of services that are going to be provided to the patient, the types of modalities and technologies that will be used to provide the services, the different types of payers that may be reimbursing for the types of services, and the types of special needs that the patient may have in their receipt of telemedicine services. Recently in the news, we've seen a lot of play about the different opportunities that telehealth can serve in fighting the recent coronavirus epidemic. These are just some headlines that we pulled from recent news articles that really illustrate the potential value that telehealth plays in fighting the coronavirus outbreak. In recent 2 weeks now, we've gotten a lot of different guidance from state and federal agencies that are also aimed at allowing for the use of telehealth to deliver healthcare services. And a lot of these rules are only going to be in place for a temporary period of time. So throughout the presentation, we're going to identify for you the current state of laws and regulations and how they apply to telehealth programs, but we're also going to give you a little bit of insight into how some of these laws and regulations have been changing to facilitate the use of telehealth to tackle the COVID-19 outbreak. So one of the foundational legal issues that we always need to think through when we're evaluating a telehealth program are what are the professional licensure requirements that apply? State regulatory boards have the authority to regulate and monitor the practices of healthcare professionals that are providing services within their boundaries. Telemedicine services, as you know, just by their very nature, can transcend geographic boundaries. That's one of the reasons why they're so helpful. If you think about the recent pandemic, being able to leverage telehealth providers in one state to reach patients in another can allow us to more efficiently provide services. However, the general rule of thumb from a legal perspective is that the healthcare provider who's delivering the telehealth service needs to be licensed in their respective profession in both the state in which they are physically located, as well as the state in which the patient is located at the time of the telehealth encounter. Many states have adopted exceptions, though, to that general rule of thumb. This slide identifies the 5 most commonly known licensure exceptions. The one that I think is most relevant and often leveraged by clients relates to follow-up care. So when you have a patient and you've provided care to that patient and then the patient goes to Florida for the winter or is a college student who then goes home for summer breaks, There are some states that have adopted exceptions that allow for that healthcare provider to continue providing services to the patient in that state without going out and securing a license within it. Another exception that is particularly popular is the consultation exception. It's also known as the peer-to-peer provider or consultation exception, which allows for a healthcare professional to do a curb consult or a side consult with another peer. So if a physician who's licensed in Illinois does a consult with a physician who's in Indiana, and it's just two peers talking to one another, that would not necessarily trigger licensure in Indiana. So the purpose of these exceptions are really to facilitate the provision of coordinated, higher quality care to their patients. We want to make things easier for healthcare providers when doing so is in the best interest of patients. And then before we move on to the last slide, we also want to highlight the Federation of State Medical Boards Interstate Medical Licensure Compact. That's the last category at the very bottom of the slide. The majority of states now have joined the Interstate Medical Licensure Compact, which basically allows for a physician who is licensed within a compact state, i.e. a state that has decided to join the compact and has adopted the appropriate legislation to do so, to practice medicine within another state via a compact license. You can get a compact license by completing a much shorter form. It has much shorter timelines. It's intended to be a streamlined vehicle through which you can receive physician licensure. So given the current state of affairs, we thought that it would be helpful to provide you with an overview of the various different states that have adopted or passed some type of emergency declaration that is aimed at waiving professional licensure for physicians and other types of healthcare professionals in order to deal with COVID-19. Right now, there are about 10 states that have passed some type of legislation. More and more states are passing them every day. The information that's provided on this slide is accurate as of the date noted at the bottom of the slide, which is March 17th. Every single day, we're seeing new updates, new states that are adopting new orders, states that are modifying their orders. So this is something that's really fluid. It's constantly changing. But as you can see, some states like Florida, for example, has declared a state of an emergency that waives licensure requirements for out-of-state healthcare professionals who render services in Florida, enabling healthcare professionals who are licensed in states across the country to deliver care to Florida patients without first securing a physician license in Florida. Other states have taken similar approaches, but may include various different caveats or requirements to go along with it. One of the states that we did not include on here because it's not an emergency declaration is Nebraska, for example, which has an Emergency Management Response Act that is intended to enable healthcare providers to deliver services when the state declares a state of emergency. Those services can be delivered within an emergency area and for the purpose of addressing that specific emergency condition. So when you compare the different states, you have a Florida that has basically waived professional licensure for physicians who are practicing and licensed in good standing in another state to deliver any type of healthcare service to patients within the state of Florida. And then you have other states like Nebraska perhaps, or Oregon is another good example, that allow for emergency volunteer healthcare professionals to deliver certain types of services and are more focused on rural communities. So as you study these state of emergency declarations, you need to really be asking yourself, how broad is the declaration? How long will the declaration be in place? And are there any limitations that I need to be thinking about or requirements, such as, do I need to notify a particular state board or agency that I am providing services within that state? So traditionally, Medicare reimbursement for telehealth has been very limited. And the reason that it's been limited is because of several requirements that CMS put in place that were aimed at of addressing or preventing what the Congressional Budget Office and other concerned stakeholders believe would result in duplicative services to Medicare beneficiaries. So the concern is that a Medicare beneficiary would receive a service via telehealth, and then that later that day or the very next day, they would still end up in their doctor's office, and Medicare would end up paying twice for something. Well, to address that concern, Medicare adopted various coverage requirements. For example, patients must be located within an approved originating site in order to receive services that are covered via telehealth. So an originating site is a hospital or a medical clinic or a physician's office. A patient can never be in their home in order for the service to be covered by Medicare. They also put in place a geography limitation that requires the patient to be located within a health professional shortage area outside of a metropolitan statistical area. So for a patient to receive services and have those services be covered by Medicare, the patient has to be within a health facility within a rural area. As you can imagine, for this reason, Medicare reimbursement for telehealth services has been very limited to date. But given the recent pandemic, CMS has changed its coverage requirements and is now eliminating the originating site and the geographic restriction that I just mentioned. So these requirements that have been longstanding barriers to Medicare reimbursement have now come down, and healthcare providers will be able to render covered services to Medicare beneficiaries and receive reimbursement for it. Now, I will note that we are still waiting for guidance from CMS about how to go about billing for Medicare, how to go about billing Medicare for telehealth services with this new regime, the new elimination of the originating site and geography requirement. We'll also note that patients who are receiving services, they are allowed to receive services through certain types of healthcare professionals. That's physicians, nurse practitioners, physician's assistants, certified nurse midwives in certain sections. And this is expanding and changing on a daily basis. So right now, the types of qualified healthcare professionals remains consistent with those that have been in place for a while now, but we do expect that this list will grow at some point in the near future. CMS has also decided that it will extend this particular waiver until the public health emergency as declared by the Secretary of HHS comes to a conclusion. And it is not limiting the delivery of services that are reimbursable by Medicare without these longstanding restrictions in place to only COVID-19 patients. So any type of healthcare service that's a Medicare covered service will now be reimbursed, and we don't have to worry about the originating site or geography requirement during this emergency period. And then finally, CMS also noted that they're not requiring additional or different modifiers to be used. So you can go about billing and using the same modifiers as you would for a telehealth service, outside of this emergency period. The next category of legal issues that we like to work through are those that relate to standards of practice. So telehealth, outside of the pandemic, is regulated by states on a state-by-state basis. And some states and their professional boards within those states have developed separate and distinct clinical practice standards or guidelines for delivering telemedicine services. One example relates to record keeping. A handful of states have telemedicine specific requirements for the documentation and the maintenance of patient records. Nearly half of states have adopted a telemedicine specific informed consent requirement that dictates the content and or the manner in which consent is secured. So some states will say your informed consent form must include a discussion of the risks and benefits of telehealth. They must offer to provide the patient with an in-person encounter if they would like it. And it must inform the patient of their ability to revoke this consent under certain circumstances. So they're very specific. Other states are just general in that they require that you secure informed consent of the patient before providing the telemedicine service. It's also worth noting that some of the states that have an informed consent requirement also dictate the manner in which the consent is secured. Some states will allow for verbal consent and others require it to be in writing. For the states that require it to be in writing, however, most states will permit you to secure that consent electronically. And in fact, I think there's a very good argument that you could secure that consent electronically in every single state, given certain of the Uniform Electronic Transactions Act and other related acts that relate to the validity of electronic signatures. And then finally, some states require a patient and provider authentication requirement. And the purpose of this is just to verify that both the patient and the provider are aware of who they are talking to during the telehealth consult. Years ago, telehealth providers would require that the patient hold up a copy of their driver's license. Today, what most telehealth companies do is a little bit less formal than that. For example, the patient is given a unique login ID and password to sign into a telehealth platform that may be sufficient for purposes of authenticating the identity of the patient. For providers, we generally just recommend that providers introduce themselves to the patient. Hi, my name is Dr. So-and-so. I'm here to provide you with a consult. I'll also note, though, that some states also require that the provider provide the patient with their credentials, which is usually just, the states in which they're licensed, perhaps even a license number, and their particular specialty. The good news, though, is that a lot of states are actually moving away from these state-specific practice standards. And then the reason is because they want to make telehealth more analogous to an in-person visit to make it easier for providers to deliver care via telehealth and not have to worry about doing extra things that they wouldn't have to do normally if in person. There are, however, states that continue to impose these practice requirements, and so we think it's really important for for telehealth providers to do the research in advance of offering telehealth services in any particular state to make sure that they are requiring what the requirements that currently exist today. One tip to note is that mid-level providers, so nurses and physician assistants and others, may be subject to their own unique practice guidelines that are different than those that apply to physicians. And then finally, we note that government reimbursement programs may have additional practice requirements that we need to comply with on top of those that we've just mentioned on the slide. So as we noted, informed consent is one of the most major practice standard requirements that we need to comply with. And one of the points that we want to highlight for you is that the telehealth modality matters. So think about how you secure informed consent if you're doing a phone consult, how you secure informed consent if you're using an audiovisual technology solution. How do you secure consent if you're using a chat-based feature? So you really need to tailor the informed consent process around the type of modality that you use so that you are in fact securing informed consent, not just consent, but the patient actually understands what it is that you are asking them to, what they're agreeing to, so that it truly meets the informed consent requirement. We provided on this slide just an example of how California, for example, governs informed consent, what they must do in order to get that consent. You'll notice that the laws, the Business and Professional Code in California has rules, but there's also rules for specific types of healthcare providers, like the Board of Occupational Therapy or Behavioral Science. None of those will apply to, sleep practice, but it's intended to illustrate that in other states as well, you may find that there are specific regulations you need to look at in addition to the laws themselves. And then finally, we'll just like to flag that Medicaid may also have its own set of requirements that you need to research, as we noted on an earlier slide. So even though the state itself may have laws and regulations, and those are often found in professional codes, in order for you to get paid for a telehealth service via Medicaid, the Medicaid program itself may have its own informed consent requirement. So continuing on, how do we integrate these best practices into what we do? Well, to the extent possible, it's always better to automate, to build the consent into your telehealth policies and workflows, to build it into the technology itself. And then, of course, you want to record that you secured the consent in the medical record. This includes that you secured the consent verbally by just notating it in the record, or that you received a signed copy, which can be uploaded into the record for storage. Finally, if you're using telepresenters, so non-medical staff who are assisting the patient with securing informed consent, and you're the distant site provider, meaning you're a provider who's located somewhere else in the world who's doing the consult, but you're relying upon a partner site to arrange for staff to assist the patient in securing that consent, it's better to have that discussion up front about who's responsible for securing the consent, who's responsible for having the patient sign the form, for uploading the form to the medical record, or for notating that the consent was secured verbally. In addition, we also like to mention that as you're developing your workflows and your policies and procedures, even outside of the consent context, be thinking about how you're gathering the patient information and who's accessing it. So if that telepresenter, that staff member who's helping you secure the consent, if they're also going to be staying in the room, is that appropriate? How are you respecting the patient's confidentiality? it's important to have people who are available in the event there's an equipment failure or there's some type of complication with the technology. But at the same time, we want to be thoughtful about who serves as the telepresenter, what information they have access to, so we comply with our privacy and security obligations, and to, of course, make sure that the patient feels comfortable. The last major bucket of practice standards that we'll discuss are those that relate to remote prescribing. So this is the area where there's the greatest amount of legal risk for healthcare professionals. States have passed laws and regulations that dictate when it's appropriate to prescribe a prescription medication to a patient based on a telehealth consultation. So there's different laws and rules that apply to controlled substances than those that apply to non-controlled substance prescriptions. Some states specifically require that an in-person or a physical exam be done prior to prescribing a controlled substance. Most states now are supportive of the issuance of a prescription based on an audiovisual, so like a video conferencing telehealth consultation. Some states are also comfortable with that consultation occurring via telephone. Most states have taken a position that it's inappropriate to prescribe based solely on an online questionnaire. So this would be like a patient who answers a fixed questionnaire of 10 questions, and then based on the responses to those questions, a provider then decides to issue a prescription without ever having an interactive real-time exchange with that patient. Also notably, while the professional boards themselves tend to be the places where these regulations are found, some pharmacy laws have also passed their own rules, and those govern the pharmacists who are filling these prescriptions. So, for example, some states like Minnesota have a pharmacy law that states that only prescriptions that are prescribed via a valid physician-patient relationship may be filled, and they have restrictions on the types of medications that can be filled via a telehealth encounter. In addition to the state laws, there are also federal laws, specifically the Ryan-Haight Online Pharmacy Consumer Protection Act of 2008. This is a law that has been around for quite some time and is complicated. We're going to look at a decision tree in just a moment. But one important point to clarify is that in the event that there's a discrepancy between the state and the federal, the stricter rule governs. So if the state has a rule that's stricter than the federal law that we're going to discuss in a moment, you have to follow the state law. If the federal law is stricter, that's the law that you should be following. So they don't exempt or preempt one another. So as I mentioned, the Ryan-Haight Act of 2008 is a somewhat complicated law. It was passed in response to a young man named Ryan Haight who received a prescription medication from an online pharmacy after completing an online questionnaire in the early 2000s. It was for a controlled substance, and he passed away as a result of that. And because of that death, and then the momentum from different policymakers, from family members, from communities, there was some outcry because he was this, really a child was able to get their hands on a controlled substance based on answering a series of questions online. A law was passed that basically requires that a healthcare professional cannot prescribe a controlled substance to a patient unless they've done an in-person physical examination of that patient. There is an exception, though, to that very strict standard for telemedicine encounters. A telemedicine encounter, so those exceptions, you'll see there's a series of boxes. It looks like there are 7 of them in total listed along the second to last level. So if a patient is located within a DEA registered facility, which is really just a hospital, and you are a telehealth provider at a different location, you can prescribe a medication, a controlled substance, to that patient without first having done an in-person exam of them. Another common exception is if the patient is in the physical presence of another DEA registered practitioner. So if you're the telehealth provider and the patient is sitting next to another DEA registered provider during that consultation, you can prescribe them a controlled substance without having done an in-person exam of them. The one that is most relevant today is the category that is the second from the right, the medical emergency situation, and then also perhaps the declared public health emergency. We're going to talk about those in a second because of the recent pandemic. But as you can see, there are a number of exceptions that were put into place here that are intended to facilitate the use of telemedicine to treat patients and to prescribe controlled substances, but the exceptions are rather narrow. And so it's really important for compliance programs, for telehealth compliance programs, to think about, one, what are the state remote prescribing rules that apply, and how do they apply to controlled substances? And then two, what are the federal requirements under the Haight Act? 2 days ago, the DEA released new guidance that allows DEA registered practitioners to issue prescriptions for controlled substances without an in-person medical evaluation for the duration of the COVID-19 epidemic. So as long as we have a declared public health emergency in place, telehealth providers will be allowed to issue prescriptions for controlled substances even if they haven't done an in-person exam of that patient. But in order to do so, there are 3 requirements that must be met. First, the prescription must be issued for a legitimate medical purpose by a practitioner who's acting in the usual course of his or her professional practice. This means that they must have prescriptive authority under state law, and they must do so in the usual course of their practice. Second, the telemedicine communication must be conducted using an audiovisual, real-time, two-way interactive communication system. So this is video conferencing technology. So in order to prescribe a controlled substance to a patient, that exam that occurs via telehealth should be done using video conferencing technology, not a telephone or an online chat or an online questionnaire. And then third, the practitioner must be acting in accordance with applicable federal and state law. So this refers to all those different laws and regulations that we just discussed a moment ago relating to professional licensure and practice standards. Moving on, another really popular topic that is worth noting relates to that of privacy and security. So as you can imagine, telemedicine tools are intended to enable the free flow of information between healthcare providers and their patients. There are different modalities that can be used. There's remote patient monitoring tools, as well as video conferencing tools and other types of technology solutions that can facilitate providing virtual care to patients. But with that creates additional problems or risks, because you have different devices and different locations where patient health information is being stored. And those security risks and those data flow pathways, they require careful studying to understand whether they comply with state and federal laws and regulations, and how we can really protect and continue to maintain the trust of patients. So there's different considerations as well that make this problem in the telehealth space a little bit more acute than what would exist in your in-person practice. First of all, there are a lot of new telehealth vendors on the market today, a lot of new technology companies that don't really have a lot of experience and don't have the resources necessarily to dedicate to true compliance, to developing a robust privacy and security compliance program. And because of that, these new tools may be used in a way that is very much appropriate from a clinical perspective, but might be very much so inappropriate from a privacy and security compliance perspective. One example that I wanted to mention are tools that enable text messaging. So a lot of health systems and different types of healthcare entities today use text messaging as a way to remind patients to fill their prescriptions, to schedule appointments, to show up for a telehealth visit. And text messaging is a very common and popular way for us to reach our patients and should continue to be used appropriately. But there are laws that require vetting. One of which is the Telephone Consumer Protection Act. So you may recall that many years ago, we would get calls at dinner time from robocalls and solicitors who were trying to sell us products, and laws were passed to stop that practice. Consumers became very frustrated with having their phone lines blow up with calls at all times of day and night. Well, one of the laws that was passed is it's called TCPA, the Telephone Consumer Protection Act, and its purpose is to really regulate and require that persons who want to contact people via phone or text message or fax have to secure the patient's consent in advance. So before you're texting patients as part of your telehealth program, or if you're even texting them patient health information, there are different laws and regulations that you need to look at and confirm that you've secured the adequate consent of the patient in advance before using these tools, because the fines that come along with violating them are quite severe. So we'd like to wrap up our conversation today by just flagging a few other considerations that are worth keeping on your radar. One is malpractice. So who truly has the provider-patient relationship? If you enter into a telehealth partnership with another healthcare facility or group, whose patient is it really? Is it your patient? Is it the patient at the facility's responsibility to maintain that relationship with the patient? The relationship changes a little bit when you have a provider who's located at one location and a patient who's located at another, potentially in the care of that other provider. As we mentioned, there's also lots of different sources of data for the patient that may be less controlled or defined. You may have access to patient information in a telehealth platform. You may have access to that patient's information in an EMR system. There may be information that's sent via text message or chat or maybe recorded. And so we just want to be very thoughtful about where the data is located to ensure that providers have access to it when they're providing their telehealth consult, but also to ensure that it's being stored appropriately in compliance with privacy and security requirements. And then we'd also like to mention the evolving standard of care. So what is the standard of care when it comes to delivering services via telehealth? Dr. Epstein provided a really great overview of what should be done in order to ensure that high quality care is provided to the patient, and that the standard that's provided, the standard of in-person care, really should be the standard that you apply when you're delivering care via telehealth. And then finally, from a patient relations perspective, how do we convey to our patients that we're providing them with these services virtually, that we're going to do so in a way that protects them and meets current standards of care for the delivery of healthcare services, that we're going to secure the necessary consents that we need to secure, and that we're going to store and protect their information in a way that provides them the comfort and maintains their trust and prevents reputational harm. And with that, Dr. Epstein and I would like to thank you for having us today. As you know, telehealth brings a lot of opportunities to telesleep practices, and in the current state of affairs with the pandemic that we're dealing with, it is truly a potential solution that could save lives. Thank you very much for having us today, and we look forward to speaking with you again soon.